So I will pass things off to you. This, again, is always a great lecture on ketamine, and there's just so many amazing things we can do with it. So take it away, Kayla.
Yeah, thanks, Joel. Hi, I'm Kayla Andres. I'm a inpatient palliative physician at Corewell Health West. Sorry, I sound a little, I'm recovering from a cold, so I sound a little froggy today, but hopefully you can hear and understand me. So today we'll talk about ketamine. Uh, I have no disclosures. So today our objectives are to be able to recall the mechanism of action of ketamine, identify the clinical utility of ketamine, choose the appropriate route and dose of ketamine for your patient, and then describe the limitation in the current literature on ketamine. So why should you care? Everything, so this is not using ketamine as a talk is not an FDA approved use. But you probably, even if you're like, I'm not going to prescribe ketamine, your patients may be receiving ketamine. There's been a proliferation of clinics, and this is just in Grand Rapids. And this, I didn't even look this year. This is from a couple years ago of places that are providing ketamine infusions. It is a cash pay as insurance generally doesn't cover it. And as you can see, it's quite spendy. So I think it's just important to know about ketamine because even if you're not utilizing it, your patients may be. But I'm hoping after this talk, you'll consider using ketamine. So we'll start with a case. NZ, he's a 54-year-old. He has a history of traumatic subarachnoid hemorrhage, chronic subdural hematoma, alcohol use. He was recently diagnosed with laryngeal squamous cell carcinoma. He underwent a total laryngectomy, pharyngectomy, a total thyroidectomy, bilateral neck dissection, cord pack placement. So a really large surgery for head and neck cancer. We are consulted post-op day one to help with pain management. The patient, we reviewed his maps. He's been on Norco for about 3 months. Around the time of his diagnosis, he was started on a fentanyl patch about a month prior to this, and his Norco was increased to 10,325. And that was when he established with his outpatient palliative care team. Post-operatively, his pain is a 10 out of 10. He's on his home fentanyl patch. He has oxycodone 5 to 10 and IV Dilaudid 0.25 to 0.5. So we make some adjustments. We increase his oxycodone. We increase his Dilaudid. And then the next day we follow up with him and pain's only slightly better. It's a 7 to 9 out of 10. He's used about 190 OMEs in the last 24 hours. So what could we do next? So while you think about that, we'll talk about ketamine. So ketamine, it is in a general anesthetic. It was first approved in 1970 as a general anesthetic. When we take the word ketamine, what we're referring to is a racemic mixture. So ketamine is this racemic mixture of S-ketamine and R-ketamine. The S isomer has a higher affinity for the NMDA receptor, and than the racemic compound. And also it's about 4 times more potent than the R, and 2 times more potent than the mixture. It's lipid soluble. It is a Schedule 3 drug, derived from PCP. It rapidly crosses the blood-brain barrier. And ketamine is an excellent anesthetic because it has amnesic, analgesic, dissociative, and sedative properties. It also has low protein binding. So the mechanism of action. So it is an NMDA receptor antagonist. It is non-competitive at the NMDA receptor. So just a little bit of talking about this NMDA receptor channel complex. So at resting, it is blocked by magnesium and drugs that act at the PCP site. So those drugs are methadone, which you all should be familiar with, dextromethorphan, and ketamine are drugs that can block the NMDA receptor complex at the PCP binding site. It's so at rest, it is blocked by either magnesium or drugs. That it's closely involved in the development of central sensitization of the dorsal horn neurons, which transmit pain signals. Um, and so when the resting membrane potential is changed as a result of prolonged excitation, the channel unblocks and calcium moves into the cell. This leads to neuronal hyperexcitability and results in hyperalgesia, allodynia, and a reduction in opioid responsiveness. So this kind of crosstalk, there's a crosstalk between the opioid receptors and this NMDA receptor that leads to our opioid tolerance and hyperalgesia. And so opioid receptor activation results in the phosphorylation and opening of this channel. And so that leads to the cascade events, which ultimately downregulates the opioid receptor and its effects. We will talk about using ketamine for pain, but also for depression. And so we're kind of getting a little bit better understanding of how it works for depression. And it's thought that the antagonism of the NMDA receptors leads to enhanced glutaminergic AMP receptors, which facilitates the transcription of prosynaptogenesis proteins, which are associated with the antidepressant effects. And also this transient decrease in the glutamate leads to AMPA activation, which can lead to neuroplasticity, strengthening of the synaptic connection, which can improve mood and enhance resilience to stress. And it's also thought that it helps restore and form new synapses, improving the brain's ability to process emotions and reduce overactivation of the amygdala. So if you are really into like how does ketamine work, I do recommend reading this article. It really provides a very detailed look at how it's thought to work for depression and pain. I think you could spend a whole hour lecture going through this, and I would probably confuse both myself and everyone here. So half-life and metabolism. So it has a very short alpha half-life of 2 to 4 minutes. So our alpha half-life is our distribution throughout the body, which explains the quick recovery after ketamine. Our beta half-life is 2 to 4 hours, which that's our elimination half-life. And so the main product, so as you can see, this is metabolized in the liver. The main product is norketamine, which has a lower affinity for the NMDA receptor than our ketamine. When administered orally, this ketamine has a high first pass metabolism, and so we'll see that when it comes to bioavailability, that the oral route is not generally the preferred route. If you have patients that have liver disease or an elderly patients with decreased hepatic blood flow, you will decrease the clearance of ketamine, which can increase the oral bioavailability. There are some complex kind of interactions. It's not as straightforward. As you can see, it's metabolized by these CYP enzymes, which are known interactions. So clarithromycin and grapefruit juice, which are CYP3A4 inhibitors, they'll increase the plasma concentration of ketamine. Rifampin and St. John's wort, which are CYP3A4 inducers, will decrease the plasma concentration of ketamine. But there is also some involvement of the P-glycoprotein because itraconazole, which is a CYP3A4 and P-glycoprotein inhibitor, do not actually not affect the metabolism of ketamine. So bioavailability. Here, as you can see, so a lot of times we're using this medication IV, which is 100% bioavailable. The duration 20 to 45 minutes. So as you can see, the oral bioavailability is quite poor, 8 to 24%. Intranasal is 45%. So this is important. It's a bit higher because as a preview, we'll talk a little bit about Spravato, which is an intranasal S-ketamine. And so the bioavailability of that is better. And then sublingual has a little bit better bioavailability than your oral, so something to keep in mind. When switching to parenteral to oral, if they haven't been on it chronically, you can usually do a one-to-one switch. You may want to reduce the if you're switching if they've been on it for weeks at a time. And then when you're switching from oral to parenteral, I would just say start low and up titrate. Um, and just for reference, a half a milligram per kilogram of IV ketamine has a similar bioavailability as 56 milligrams of intranasal S ketamine. So we'll talk a little bit more about that later. Dosing. So what's important here is that there's no standard dosing strategy. So I think we are, especially as we move into all the data and all the studies looking at it for depression and mental health disorders, we are kind of moving into where we are getting more standard dosing. But I would say for pain, the dosing is all over the map. And so when you are looking at studies, I would like kind of look at like what dose did they use to kind of help gauge, as you as appraise the evidence that you're looking at. When you are doing weight-based dosing, I do recommend using ideal body weight, particularly if you have a patient that is overweight or obese. Generally, if we're giving a bolus, we're giving 0.25 to 0.5 milligrams per kilogram. You can go up to a milligram to kilogram. And I would say run the bolus over 40 to 60 minutes. I would say in all the literature, they run it over 40 minutes. I generally in practice do 60 minutes just to slow it down just a little bit. I also just feel like an hour is a nice round number versus 40 minutes. And then you can follow it, or you could just start a continuous infusion. If you're doing milligram per kilogram per hour, it's 0.05 to 0.25 milligrams per kilogram per hour. In our institution, we don't do weight-based infusions. Our infusions are just milligrams per hour. So I'm generally starting 5 milligrams per hour is usually my starting dose. You can go as low as 2.5. So if you have an elderly patient, that may be a better starting dose. You can also start a little higher, 7.5 milligrams per kilogram per hour, even 10 in some really severe situations. Here's some dosing for subcutaneous. So it can be administered subcutaneously. And then oral, I would say start with a half a milligram per kilogram per day and divide that into 3 to 4 doses, and then you could increase that up to a milligram per kilogram per day. When we're using ketamine for anesthesia, generally we're talking 1.5 to 4.5 milligrams per kilogram per hour. And so when we're using significantly below that rate. So generally for analgesia, you're doing 0.1 to 0.5 milligrams per kilogram per hour. My box goes away. So dosing for depression. So I included this because this is where we are really starting to get some standardized dosing, and that's kind of where the half a milligram per kilogram in the 40 minutes is coming from. So there's a couple small randomized controlled trials for depression. I believe one of them was in patients with advanced illness as well. And they found that so they used placebo, which was Versed, and then or midazolam, and then they looked at ketamine compared to midazolam. And as you can see in this graph, so this HAM-D6 score is their depression management, depression screening score. As you can see, compared to midazolam, which is the blue line here, ketamine at all doses had a significantly improved depression score. And then when you stratified this out by dose, so we have our top line is our placebo, which is midazolam. When they stratified it out by dose, what they found is that 0.1 milligrams per kilogram and 0.2 milligrams per kilogram, they were not superior to active placebo. but 0.5 milligram per kilogram and 1 milligram per kilogram were superior to active placebo. Um, I attended a talk HPM that was on rapid management of anti of depression. Given a lot of our patient population have very limited time, so waiting 4 to 6 to 8 weeks for an SSRI to become effective is really just not practical for a lot of our patients. And they did talk about using ketamine. And a couple of pearls that I picked up. So they were using 0.5 milligram per kilogram, and they're actually giving it intramuscularly. And they were doing that weekly for depression. And then, and I did find this in newer studies confirming they had mentioned that when we are trying to treat for depression, having a dissociative event during treatment, and especially when initiating treatment, is associated with more like more likely to respond to the ketamine for your depression. And so if you pick a dose, like let's just say you want to be really conservative and you only give like 0.4 milligrams per kilogram of ketamine and the patient's like really felt nothing there, you probably did not give them a high enough dose to actually treat their depression. So we are targeting a little bit of a dissociative effect when you are trying to manage depression. Obviously, you want to keep that dissociation pretty mild. Um, Adverse events. So I would say generally I find ketamine is quite well tolerated. Things you're looking for: dizziness, hallucinations, difficulty concentrating, vivid dreams, anxiety, hypertension, tachycardia, increased salivation. You can treat these. Some people give benzos or alpha 2 agonists or even Haldol when they're giving ketamine. I'm gonna be honest, I never give any of those, and I like don't generally have a problem. If you are treating depression, there is some thought that you want to avoid benzos because you really do kind of want to get them into that a little bit of dissociation so they can get the antidepressant effect. So I think I do see, people say they have vivid dreams. They will sometimes say they have dizziness. Sometimes patients, especially if I'm giving that bolus, they'll say they maybe had a little bit of like hallucinations, but they all resolve very quickly after you give the bolus. So I do just try to assure patients, you may experience this. If you do, call your nurse, and if it's bothering you, you can stop it. It will go away very quickly. Um, Chronic use, we don't have a lot of information, but it has been known to cause interstitial and ulcerative cystitis. There is some risk of addiction, hepatotoxicity, and neurocognitive impairment. Um, there are case reports that it can cause QTC prolongation. That's not something I generally worry about. In anesthetic dosing, in the anesthesia literature, they do avoid using ketamine as part of the anesthesia regimen for patients with congenital long QT. But it's not something I'm regularly monitoring or worrying about with ketamine. And then there have been some concerns about ketamine can increase the intracranial pressure and that you should avoid in patients who cannot have an increase in intracranial pressure. That's a theoretical risk. The literature, while not really conclusive and complete, but what data we do have really doesn't bear that out. So they've looked at patients who are undergoing craniotomies for brain tumors or cerebral aneurysms. And when they measure the cerebral blood flow and intracranial parameters during surgery while patients are receiving ketamine for their anesthesia, they didn't show increase. And there's another small study in children that with increased intracranial pressure who received ketamine didn't have worsening of their intracranial pressure. I've also heard avoidant patients with cardiac and cerebral vascular disease who cannot tolerate blood pressure increases. I don't really see this. There's not literature to support this avoiding in these patients. And I do think it does not cause hypotension. So one thing we worry about with our patients in the ICU is that you don't want to worsen their hypotension if they're already on pressors. So this could be a good consideration. So what does the evidence say? I think, so this is just for pain, and the kind of the evidence is all over the place. In general, the studies we have are pretty low quality, kind of mostly small randomized controlled trials or case series. in some different pain syndromes. Patients with CRPS, they did have pain benefit after their infusion, but it didn't actually translate to functional status. And that was consistent across a couple different studies. There is a little bit of data for ischemic leg pain and acute limb ischemia in patients who received IV ketamine, just a single infusion. And it did show in both of these small randomized control trials decrease in pain, ability to enjoy life. There was no statistic in the one study, there was no statistically significant difference in opioid use. For neuropathic pain, I think the literature, there's quite mixed results. Some have shown positive results for ketamine on neuropathic pain, and some have not. And then, there was a meta-analysis and trial sequential analysis of randomized control trials, and they concluded that ketamine was ineffective for chronic non-cancer pain. But when they excluded studies with a high risk of bias, ketamine was found to decrease pain at 4 weeks with moderate level evidence. So I think there's some inklings that there's evidence to support it, but nothing super conclusive. And then for cancer-related pain, because this is kind of what most of us are probably treating or why we're thinking of reaching for ketamine. There's a 2017 Cochrane review that said that the current evidence is insufficient to assess the benefits and harms of ketamine. Randomized controlled trials have not really shown significant benefit, and then case reports and case series demonstrate a positive impact. I do want to highlight, this was a recent study a couple years ago. I think it was in the Journal of Pain and Symptom Management. So if you're like looking ketamine cancer pain, this is probably the study that comes up. And so they did this review, and they have there was they had 35 studies and 2,279 patients. So there was a large group. Dosing strategies varied. And so, I think if you see here, this is kind of taking a look there. When they look at all the studies, it favors the experiment, which is ketamine. And they concluded that ketamine may be used as an effective therapy to relieve cancer pain. I want to kind of challenge you to think about that, if that's accurate. I think that was a bold claim that I don't know that they could really make. But when we break down the ketamine by how it was administered, so at the top here, this is an IV PCA. I mean, we just generally don't use ketamine as a PCA, so it's a patient-controlled IV. And as you can see, it crosses the midline, so that's not conclusive favoring of ketamine. And then this one here, obviously it favors the experimental, but this is a patient-controlled epidural analgesia. And so that was actually the only method which ketamine was administered that did show a positive effect over the control. This is a subcutaneous here, and again, it's right at the midline, and then oral also at the midline. And so I think there were a lot of high risks of bias in this study as well. So I mean, I think it's kind of interesting to think about using ketamine epidural, but I wish this was more, the studies were more how we use ketamine, which is oral or sublingual or IV or intranasal, and not these patient-controlled analgesias or epidural, which we just generally don't use. So. Acute postoperative pain. I think overall, I would say there is actually some decent studies that support the use of using ketamine in the postoperative pain. And so, I think the conclusions are perioperative IV ketamine probably reduces postoperative analgesic consumption and pain intensity. These results were consistent in different operation types, the timing of ketamine administration. with larger, smaller studies and by higher and lower pain intensities, and that the CNS adverse events were a little different with ketamine or control. So it probably reduces postoperative nausea and vomiting by a small extent as well. When you think about giving opioids as the alternative or higher dose opioids as the alternative. Um, and so I think I would say that I feel, as I've looked through the evidence for postoperative pain, I do think that this evidence is a little higher quality than for our cancer pain and our chronic pain, and does seem to suggest benefit. This was also another review from, I think, a couple years ago. It had 905 patients with that received ketamine. It was a variety of surgeries, from like abdominal surgeries to chest surgeries, different. And they kind of looked at ketamine. So this first is rest pain after surgery. So the top is 4 hours after surgery, 12 hours after surgery, 24 hours after surgery, and then 48 hours. And at least up to 24 hours, the studies favored ketamine. And then this looked at morphine consumption, 4 hours after surgery, 12 hours after surgery, uh, 24 hours after surgery, and then 48. And as you can see that it did decrease consumption with ketamine. There was quite a variety, some were boluses only, some studies were boluses and infusions. All of them had to start ketamine before the procedure, and then the duration after the procedure varied. So some studies they stopped like actually at the end of surgery, and then other studies continued on for either 2 hours postoperatively or up to 60 hours postoperatively. So there was a lot of heterogeneity here, but I did think that these results were just encouraging that ketamine can be helpful in the postoperative period. All right, back to our patient case. So this is a ketamine lecture. So if you didn't guess ketamine, it should have been obvious. We started our patient on 5 milligrams per hour of ketamine. We reassessed him later that day, and his pain actually decreased to a 0 out of 10. Unfortunately, overnight, he had some ST changes on the monitor, and ketamine was discontinued. But he was in the ICU, and so the surgical ICU had stopped it. The next morning, his pain was a 9 out of 10. His OMEs were 180, so were about consistent from what they were before ketamine was added. So we recommended restarting the ketamine. We restarted at 2 milligrams per hour. He had a significant decrease in his OMEs to 80 milligrams, and he hadn't used any IV Dilaudid. The patient was having hallucinations, so they did stop the ketamine. Upon review, he was having hypoxia and mucus plugging. Of course, hindsight's always 20/20, but it was maybe stopped a little bit premature. But the patient was maintained off ketamine over the rest of his hospital stay. His fentanyl patch was increased and his IV Dilaudid was stopped. So I do think that, so this is just kind of an example of using ketamine in this is a real patient that I saw, so that using ketamine in that post-op period. Of course, this one was a little fraught with some complications, but I do think that it did help his pain. It went, he had severe pain, 8 or 9 out of 10, and we were able to bring it down to a 0 out of 10. I just wish he had been able to stay on it a little bit longer. So, all right. Well, now I'm kind of move into talking about ketamine for depression. So this is a 73-year-old lady with a history of hypertension and coronary artery disease, hyperlipidemia. She was admitted to the hospital with perforated diverticulitis. She underwent surgical intervention. Her hospital course has been filled with complications, including poor wound healing, but her overall condition is improving and she's nearing discharge. You are consulted on hospital day 27 because the patient is refusing to get out of bed, work with PTOT, eating poorly. Her goal is to return home. You rule out that there are any unmanaged symptoms contributing to her mobility and poor oral intake. She describes feeling hopeless. What would you do? All right, so we'll talk about depression. Um, Kind of talked a little bit about the dosing. I did find this study was referenced at the AHPM here on the right, the talk that I went to. And I found it interesting, particularly for patients with suicidal ideation. So this was a small randomized controlled trial of 42 patients newly diagnosed with cancer. And they had moderate severe depression and suicidal ideation. So they received a single dose of ketamine, 0.5 milligrams per kilogram over 40 minutes versus midazolam as the control at 0.05 milligrams per kilogram. And as what you can see here is these are different suicidal ideation and a depression screening compared to midazolam, which is the top line in all of them, ketamine at day 1 and day 3, and these are statistically significant at day 1 and day 3 after a single dose, improve suicidal ideation compared to midazolam. And at day 7, there was no difference between the Versed and the ketamine. And so I thought that was pretty nice because patients can come in like acutely suicidal. And so like what can you do quickly to help them? And so ketamine is a promising therapy for that. Most doses for depression are in single dose studies where they are just giving that one bolus. There are a few multi-dose studies that were giving oral ketamine nightly that improve depression, or giving weekly ketamine too if you're giving IV or intramuscularly. This was a review from 2019 that looked at ketamine and depression. Um, and and so these are different time points after receiving ketamine. And the articles in the blue boxes were studies that showed positive effect of ketamine at these different time periods. So the studies just correlate to a study number, where the um, red boxes were studies that did not show a positive effect for ketamine. And so as you can see, the blue boxes and the numbers in blue definitely outnumber the red. And then this study looked at ketamine with ECT as well, and also found a positive benefit with ketamine in the setting of ECT therapy. So. And so this brings us to esketamine or Spravato. So you've probably heard of this. So this, when we say esketamine, we're referring to the S-ketamine isomer. So this is a product that is just the S, where all the infusion studies I've mentioned have been the racemic mixture. So this was approved for treatment for treatment-resistant depression by FDA in 2019. Treatment-resistant depression is defined as failing 2 or more antidepressants. It is an intranasal preparation. You have to be a psychiatrist and you have to have some specialized training to administer this. When it's given, it has to have a REMS monitoring program to keep track of your medication. And then after administration, you have to be monitored for 2 hours, and that's because up to 50% experience sedation in the study. Generally, the dosing is 56 milligrams at day 1, and then it's followed by 56 or 84 milligrams twice weekly for 1 to 4 weeks. That's the induction period. And then you can do maintenance therapy with 56 or 84 milligrams for weeks 5 through 8. As you can see here, the number, so there's these studies, the SYNAPSE study, and then there's the Transform 1, 2, and 3 study. As you can see, the numbers needed to treat are really good. So for reference, a number needed to treat for an SSRI is 7, and a number needed to treat for a TCA is 9. So, like in the Synapse study, the number needed to treat was 4 and 3, which is just phenomenal for any drug, really. The number needed to harm for Spravato is 178, and so that's not clinically significant. And as I mentioned, as we kind of study this more, it is suggesting that having that dissociative event during the first week of treatment is associated with depression response. This study looked for maintenance therapy. And so what I wanted to show here is that these case reports for using ketamine for maintenance therapy beyond 4 weeks and did not show a lot of adverse events. That's kind of the key here. There was a very low dropout rate of only 2 to 4%. And then the most common cause for dropout was relapse of their depression. IV ketamine. So after discussion with our patient, she's agreeable to start an SSRI and ketamine at 0.5 milligrams per kilogram of ideal body weight, and I run it over an hour. You follow up the next day and she's feeling about the same, but the nurses note some subtle improvement in her cooperation and cares and oral intake. The patient is agreeable to a second bolus, and so you repeat the same dose. The following day, the patient does report improved mood. She's working with PT that day. And then over the coming days, her intake and cooperation with nursing and therapy improve, and she's able to discharge to subacute rehab. You could consider if you do not have an effect with your initial, even if you start at 0.5 milligram per kilogram, and let's just say the patient has really no effect on their depression, they didn't have any sort of dissociative event, you could, no other adverse events, you could increase it a little bit beyond. I wouldn't go above 1 milligram per kilogram, but at least there was one study that they did give 1 milligram per kilogram, which was effective, but did have an increased risk of adverse events. So you could go up to 0.6 or maybe 0.7. I would just slowly go up. I wouldn't go from 0.5 to 1, but something to consider if patients aren't getting an effect for depression. This is probably a little bit outside of our area that we would treat, but I just kind of wanted to show for the kind of frontier of ketamine in the mental health space is wide open, and I think we're going to have more things that are approved treatments for that ketamine is an approved treatment for. And so this is a very positive study for chronic PTSD. And of course, we all know that PTSD is a really challenging syndrome to treat, and that there's not a lot of great options, and the healthcare costs and consequences are just so high. And so this study, they looked at 0.5 milligram per kilogram compared to Versed over 2 weeks. And as you can see that compared to midazolam, ketamine had improvement in their PTSD symptoms. Moving on, I have another case. So this is a 76-year-old female with a history of stage 3B right-sided breast cancer, type 2 diabetes with diabetic retinopathy, hypertension, GERD, OSA. She has a history of herpes zoster, osteoarthritis, and history of PE. She underwent a mastectomy, chemotherapy, radiation treatment for her cancer. She did not tolerate electrical therapy. Unfortunately, shortly after her completion of her treatment, she developed shingles in the same area of her breast cancer. Her pain is located in the right oblique right side of her torso. She describes it as a sharp stabbing pain. She is not able to tolerate a bra or a shirt, as the lightest touch worsens the pain. She rates this as an 8 out of 10 today. She feels an acceptable level of pain would be a 1 to 2 out of 10. She's tried Norco, oxycodone, Dilaudid, gabapentin without much relief. She finds lidocaine topical somewhat healthful, but the relief is short-lived. She's also been on Lyrica, 150 milligrams BID with minimal relief. So what would you do? for this patient, she has either post-mastectomy pain versus a post-herpetic neuralgia. Um, and so I prescribed this topical ketamine 10%, clonidine 0.2%, gabapentin 6% cream, lovingly called the Mulder cream, as it was kind of invented by John Mulder. And so I started her on this cream 3 times daily as needed. And then I saw her in follow up, and she actually reported it had been very helpful. She's able to tolerate wearing a shirt. She can lay on her right side in bed and is tolerating the bedding on her chest. She's optimistic that she can tolerate getting her mastectomy bra and is excited to get fitted for it. So I had a really good experience with this topical cream. And I've used it multiple times in patients with post-herpetic neuralgia or shingles, even. I will say though, insurance does not cover it, and so um, it can be cost prohibitive because you're getting a supply for $70 or $80. So
How long does this supply last?
it depends on how often they use it. So if they're using it consistently, probably a month. If they're not using it, they can stretch it out. So this patient, she actually was part of Care Resources, so they just covered it for her, which was really good. So topical ketamine, the data is quite inconclusive on whether topical ketamine is helpful or not. I would say a lot of them use a very low percentage of ketamine. Our cream the cream that I use is 10% ketamine. A lot of these are 5% ketamine, or I think here at our hospital, we only have like 1 or 2%. It's very low percentage. And so there has been some benefit. There's a study in venipuncture patients that compared 10% ketamine to 5% EMLA cream versus cold cream, and that the ketamine and EMLA was significantly better than placebo, which was the cold cream, but there was no difference between the EMLA cream and the ketamine cream. Not super conclusive evidence to support it, but again, there's kind of a variation in what percentage of ketamine. There was one study that did show using ketamine swish and spit for refractory mucositis, and that 5 of the 8 patients had improved symptoms, but 4 of the 8 had side effects. And I just want to highlight, I think that's like an interesting use of ketamine, but the sublingual route, like ketamine can be absorbed sublingually, and the bioavailability of sublingual ketamine is actually better than oral ketamine. So you do have to expect, if you're going to use it in this way, that people are going to systemically absorb the ketamine and get the systemic effect. So just be mindful with your dosing. In the pediatric population, so it is safe in children. It's used for anesthesia. These were some studies looking at if it was safe in kind of pain conditions. And so they gave different doses of 0.25, 0.5, 1.5 milligrams per kilogram dose. There's 11 children in the study, 3 times a day of oral ketamine, and for 2 weeks, and they didn't have any changes in their neurocognitive scores. So it doesn't seem like, if you're using it outside the anesthesia period, that there's any at least significant acute effects. The one study I have found in pain was a longitudinal cohort study of 63 children. And they gave an infusion of 0.1 to 0.3 milligrams per kilogram per hour for 4 to 6 hours. So they've given that over 4 to 6 hours, and then 3 consecutive days. And then when you look, so as you can see there, it was a decrease in pain after receiving ketamine compared to baseline. When they start parsing out different pain syndromes, CRPS had a more significant decrease in pain compared to other pain syndromes. And then when you parse out the other pain syndromes further, trauma and POTS had a more significant decrease in pain syndromes compared to headache, cancer-related pain, or other, which was like sickle cell um, and diabetes pain. So, dependence, addiction, abuse, long-term effects. And so it's largely unknown. There is thought like chronic use leads to long-lasting memory-related deficits. It is used as a drug of abuse in club and rave culture. Most of the data on the addictive potential is in mice. We really don't know the long-term sequelae, and we don't know the long-term sequelae of uh, ketamine that's prescribed medically, because a lot of the like more chronic long-term effects are by people who are getting like straight ketamine and using it illicitly. There is only case reports of withdrawal, so generally that's not something you have to worry about. Unless you have people on it for, like weeks at a time. I generally, if I have someone on a higher dose infusion, like 10 milligrams plus, I will stepwise bring them down. But if they've only been on it for a couple of days, you can really turn it off. But the symptoms of ketamine withdrawal could include palpitations, tremors, sweating, anxiety, depression, and insomnia. And then, of course, I put a picture of Matthew Perry because he famously died and was using ketamine to manage his depression. At the time of his death, he reportedly had anesthetic levels of ketamine in his system. So, all right, summary and final thoughts. The literature on ketamine uses a wide variety of dosing strategies. I think we're getting more standardized dosing. I really think a 0.5 milligram per kilogram is kind of should be your go-to when dosing ketamine. Many of the reviews on ketamine point to low quality of evidence and conclude more studies are needed to prove efficacy and long-term safety. I would say consider ketamine for depression in hospice patients with a life expectancy of days to weeks. And I actually anticipate this to expand. And I would say, even with some of our palliative patients where time is more limited, I think the data for ketamine has just been so positive that I think the risk benefit profile really weighs benefit when you've got someone that's looking at a shorter life expectancy. And so despite that the evidence for ketamine in cancer patients is inconclusive, I do feel there is a role for ketamine for patients who are not responding to opioids or experiencing opioid toxicity. So I do use quite a bit of ketamine in post-operative pain, particularly these large head and neck surgeries that are just incredibly painful. And I do think in a pain crisis, if you're not making good progress with your opioids, you're escalating opioids, and pain is not improving, I definitely think I would add some ketamine to the regimen to help kind of get them out of their pain crisis. So I have lots of references. Questions, thoughts, concerns?
Kayla, I have a question. I guess a couple questions, specifically about topical ketamine. So my prior life, most recently, was doing wound and hyperbaric over there at Cornwell, and in the wound clinic, we compound ketamine spray for patients with painful wounds for dressing changes. And then when they're in the hospital, it always gets hard because it's not available in the hospital and yada yada. And then from what I had understood is you guys in the palliative service had found that or felt that topical ketamine didn't demonstrate utility, and so you weren't using it anymore. I don't know if it's just the spray or I was just curious what your guys' like group think is on that. Not you, you personally might have some thoughts, but I just wanted to know.
I mean, I guess I'll give my thoughts, and then I'll have Dr. Rowe here because she has more experience. I used it a lot in hospice, the ketamine spray for wound, because our goals are just a little different. We're not generally trying to heal. when in my outpatient palliative practice, I was getting quite a bit of pushback actually from the wound care clinic that they didn't want like the spray or creams or anything that could be moisture on the wound. So I would have loved to have used it more.
Wait,
But I actually got
which wound clinic?
uh
Corewell or Trinity?
That would
not
be
Corwell
Yeah,
and
because
not Trinity.
that's fine, because Corewell, because that's the one that, like, we were asking for it to be used inpatient for our wound patients, but the palliative team would not order it, like, help us get it because they felt like it wasn't, like, didn't have efficacy or, it wasn't proven benefit, so that they had stopped using it, so.
I guess I would say here, I think we only have 1 or 2% on formulary here in the hospital, cream only.
Yeah.
And so I think that would be like my thought is like if we had maybe a more effective, like a 5 or 10%, like I think I would be very in support of that. I'm not, I mean, definitely ordered the 1%. I just don't know that it's really
Oh, yeah,
helping.
no, I mean, we'd order the higher from Keystone for the spray for the outpatients, but it was just while they were in the hospital, they needed something, ordered. So maybe that was the confusion, that they couldn't get the high dose in the hospital.
Yeah.
I don't know.
Right. And
But
then
anyways, it's good for, it
Oh.
shouldn't affect wound healing, but that's okay.
It might be my microphone.
okay, I can sit right there. Yeah, in my experience is, I mean, we used to use a lot, the 2% early on, but I think that we were like, is this really the 2% evidence base? Is it actually helping your patients or not, and can they actually afford it afterwards? I think we just stopped using our little 2% cream that we have available here. But if someone's ever on any cream, sprays, things like that at home that are effective, there's just an order we can put in. Can't remember. We just had it this week. It was like a non-formulary, and then they have to sign a paper that all risks are on the patient if they take a medication that we're not having on formulary. So we can do that for any
Okay.
patient.
Yeah.
So I'm not completely against like Kayla's patient had benefit. I think there's some benefit, there's a cost, and maybe there's not robust evidence. Does this actually absorb or what's going on? But I think it's just, we have to use our best judgment, and there may be cases that's really, it could work.
Yeah, and maybe it's the, the dose is the poison, or, meaning like you got to get it to a high enough level to make it worthwhile. So
one other thing we were talking about here, Kayla, and maybe Bruce, I'm going to try to phrase it this way. Let me know if this is the question you have. But looking at the studies with depression, it looks like they used midazolam quite a bit. And you were using the word placebo. Were they specifically saying that was placebo versus a control? And do you know why they chose midazolam as that drug?
Yeah, they refer to it as an active placebo. I don't have a great sense about why they chose midazolam.
Okay, makes sense. Probably.
Yeah, that's
so
most.
they know if they had it or not.
Yeah,
It gives them a feeling that
Right.
they're getting some sort of drug because they've got something happening when you take it.
right. So they weren't treating depression with midazolam as like standard of care. It was giving the patient who didn't get ketamine the sense of receiving some kind of a
yes.
CNS, effective drug. Yeah.
Yeah.
That makes more sense.
Good job.
Strong.
Kayla, I was going to ask you about the use in ischemic pain. I feel like we're getting more and more patients with ischemic limb pain, could be phantom pain post-op, and just wondering if you'd had cases. I know you presented there was a case and it was 20 patients.
Yeah.
But if you've used it for that, if it's something you'd recommend.
Yeah, I haven't had a lot of use personally. There was 2 studies in like acute limb ischemia, and that single dose of ketamine was really
single dose.
Yeah, it was a single dose. So one patients were like non-operative, like they were not planning on surgeries, they weren't a candidate for surgeries, and so they found that it like decreased their pain and also just like increased their quality of life as well. So I wonder if maybe they got a little bit of antidepressant effect from it.
Which a lot of them have depression,
Yeah.
life changing surgeries.
Yeah. I think we've had a couple patients on our service that have had ketamine as part of their regimen. And I do think it may be worth, especially if we can try to do some opioid sparing management with them. I think in the post-op studies, it has shown to kind of decrease overall opioid consumption. I don't think we have that data in like acute limb ischemia yet, but I think it's definitely worth a try and maybe using it more like frontline for like a short, like 24 to 48 hours post-op just to get their pain managed.
And a quick second follow-up with depression. So we tend to use more infusions here in our team if we're using it for pain. If you had a patient with pain and depression, do you feel like that dosing that we typically use, whether it's 5, 10, 15, whatever, for a few days or whatever that may be, would that have the same effect as that one bolus over an hour that's a higher amount?
Yeah, that's a good question. I think with the kind of emerging that like having that little bit of that dissociation is more likely to predict a positive impact of the ketamine on the depression. I'm thinking that just starting a basic infusion is probably, you're not going to get to that dissociative dosing. And again, like our goal is not to like send people, I think, super deep into dissociation. You just want them to have a little bit, just a little, feel a little bit light.
Right into the K-hole and pull them right back.
Yeah, the goal is not to send people to the K-hole.
Do you have that discussion with the patient before you get this started? Like, look, this is an effect that we're actually looking for, so let me know when this starts happening.
Yeah, I mean, because I feel like when I give a 0.5 milligram per kilogram, most patients like experience something. So I am very clear when I'm talking to them because it is an off-label use of ketamine. So I'm saying this is an off-label use, but there is actually a lot of data to support it. So I'm very transparent with my patients. I think it'll help you. And I said, you could experience hallucinations, you could experience vivid dreams. You may experience dizziness. I say a lot of people just fall asleep take a nice little nap for a bit. That's most people when you give them that bolus is they just take a little snooze. I said, if you experience these and they're distressing, we can stop it. It all goes away. I just try to assure patients I'm not going to make you permanently have hallucinations or vivid dreams, and just encourage them. And most people are okay with that when you just kind of let them know what to expect, that they may see these things. And because I do find when I give the 0.5 milligram per kilogram, a lot of people do experience at least something.
Kind of going with that, I know you said it was beneficial for them to have a dissociative effect or a mild one with that first dose. Is that with every dose you want them to be in that or just the first?
No, I think what the literature is saying, just kind of like that initial dosing. So like the first time that you're giving it or the first couple times you're giving it, you want them to have a little bit.
I wonder if there's any benefit to, I know we use it in the ER when I was using it to sedate kids, I sort of coach them or the child life specialist into a positive dream experience. And because you could have scary, vivid dreams. And so if the goal is to get to dissociative state, I'm curious if anyone has studied or would study pairing our social work or with them when they're getting it, just helping them could, if they had it paired with someone who's coaching them through what maybe things to.
They're also going to probably have an emergence reaction too.
Yeah, definitely. Yeah. But I think that could be extra powerful.
Yeah. I think in HPM a couple years ago, there was a lecture and it was like a ketamine clinic, like kind of like what I showed at the beginning, but they were doing that. They were like having like a coach or a counselor there as they were experiencing ketamine. I also suspect that's why with like Spravato, the FDA approved product, it has to be monitored just in case people are having bad dreams. Yeah. Any other questions?
Clarifying question. Did you say it has to be for depression indication? It has to be prescribed by a psychiatrist or
If you're using the nasal spray, so
What is it?
you
It's like,
can get the racemic mixture, especially like if you're doing hospice care, if you have a
Right.
compounding pharmacy that you work with. One of my partners in the past, they would do oral ketamine and do like 3 to 5 days in a row of oral ketamine for depression. So that may be a more feasible option. Or I don't know, like about getting like an intramuscular injection. I know the guy pointed out like it seems kind of cruel to give patients on hospice care an IM injection, but he really said it wasn't that bad. Most people are fine with it. It's just a quick little poke. So
Most people
they
tend
were
to do
doing
really
that.
well just that oral dose, whether you do it just a one-time dose or 3 days in a row. I'd much rather do that than try to get a psychiatrist in S-ketamine
Right.
Yeah.
setting. I mean, I'll even do that. I haven't done it recently, but just in a palliative setting, if you know somebody's got that refractory depression and have a terminal illness, you're probably going to be better off coordinating something like that in the short term.
Good to know. Thank you.
I had a quick comment here. I know we're getting short on time, but I've kind of been looking at using this intranasal for pain crisis. Like if you have a patient that you don't have loses access, you can do a one-time dose. A lot of the EMS protocols will use 0.3 up to 1 milligram per kilogram intranasal for like acute pain, just to kind of get things controlled, and then you can kind of move forward. So I'm going to throw that out.
Yeah, thanks, Ken. Yeah, there's a nice comment in pediatric from Sandy Brower. In pediatrics, ketamine seems to have an evolving role in managing pain refractory to or insufficiently managed by opioids and other adjuvants, pregabalin, gabapentin for patients with intestinal hyperalgesia and significant neurological impairment. So very interesting. Thank you for sharing that, Sandy. Any other questions?
Great overview,
All right,
Kayla.
thank you.
Thank you. Thank you, Kayla.